Good evening, Dr. Suresh, Dr. CRS, Dr. KRP, and all senior doctors who have joined in this evening session, academic session on a very interesting topic on a new molecule. Beyond benzodiazepines, anxiolytics, they are focused on etifoxine. I take this opportunity to invite Dr. CRS, the chairperson for this evening, and Dr. KRK, who is the co-chair for this evening session. So I would like to introduce Dr. CRS. Dr. CRS has got an immense experience of more than 40 years in the field of mental health.
இது நம்ம தெரிஞ்ச ஆடியன்ஸ் தானே
எல்லாருக்கும் சார் அது இது ஃபார்மாலிட்டி சார் and Dr. CRS is well known as Dr. CRS from Madurai. He has been awarded with the PhD community set in the psychiatry at the Madurai Kamaraj University. His area of interest is community psychiatry, psychosocial rehabilitation, and de-addiction. He has been teaching various postgraduate students for more than 25 years. He has been awarded Dr. Abdul Kalam Seva Ratna Award in 2015 for his from Holiness Dr. Dalai Lama in recognition of his outstanding service in the field of de-addiction. And he also got in 2021 the Lifetime Achievement Award for the Indian Psychiatric Society, South Zone, for his contribution in the field of psychiatry and rehabilitation. Dr. CRS is the Vice President of the WPR Southeast Asia region currently and founder of Chellamittu Trust and Research Foundation. He is a senior consultant psychiatrist in the Hana Hospital, Madurai, and state nodal officer. He is in the Police Wellbeing Program, Tamil Nadu, and he is the member of the 5th Police Commission, Tamil Nadu. I welcome Dr. CRS for this program, and I like to introduce Dr. K. Ramakrishnan, who is very, very simple with his profile. K. Ramakrishnan has got more than 25 years of experience in the field of psychiatry, and he is the Chief Consultant Psychiatrist, Managing Director, CEO of Asthma Hospital, Trichy, with more than 33 years of in the field experience in the field of mental health. He is the past president of Tamil Nadu IPS as well as IPS South Zone. I hand over the session to Dr. CRS and co-chairperson Dr. KRK. This program will run, Dr. Suresh Kumar's lecture will run around for 1 hour, and any questions audience can reserve it after 9 o'clock. After the lecture around 9, it will end around 9 o'clock. Thank you.
Good evening to everybody. Am I audible?
Yes, sir.
Right. Good evening to everybody. It is always a great privilege and pleasure to preside to Suresh Kumar's session. And also it is a very difficult for me to introduce Suresh Kumar to this august audience, because it is just like introducing actor Vijay to Tamil audience, or Mohanlal to Kerala audience, or Modi to BJP cadre. He is such a familiar face. He is an intellectual giant, and also he is pride of Indian Psychiatric Society. So really, for us, we are all fortunate to hear his the views about the non-benzodiazepine anxiolytic, the drug which is recently introduced by Sun Pharmaceuticals. If you go through the history of benzodiazepine, almost it dates back from the year 1960. And so far, the past the 40 years, benzodiazepine practically they dominated the scene especially in addressing the anxiety features. And especially before that, before 1960, barbiturate was the only drug. It was acting as an anxiolytic and as well as antidepressant. Then came in the year 1960, Librium was introduced. It hit the market like anything, and it was the fascinating drug at that time. Then again, in the year 1958, diazepam was introduced by Roche Company. That the name was Valium. And in fact, to see the prescription of the Valium from the psychiatrist pad or from the general practitioner, it was really a thrilling experience. And even though it hit the market like anything, the people slowly, after few years, the people started realizing the side effects, dependence, withdrawal features, and many of the sedating aspects. So again, the pharmaceutical people, they did lot of work, and in 1975, they brought out clonazepam, and 1977, they introduced lorazepam. Again, these drugs almost practically they played a very, very important role in addressing the anxiety features. But whatever said and done, for the practical psychiatrists, for the practicing psychiatrists like us, the biggest problem is the sedating nature of the drug. What, especially the people who are going to the office, especially during the morning hour, prescribing the benzodiazepine and the drugs, it causes some sedation. And another important thing is the withdrawal features, dependency. That is the main the problem we are facing. So far we have faced. At that time only, now we have in the armamentarium of psychiatrists, now there is another drug, it comes to the armamentarium, that is etifoxine. They claim it is a very powerful anxiety, the anxiolytic, and also superior to the clonazepam and lorazepam, about which Dr. Suresh Kumar is going to deal in an extensive way. Now I request Suresh Kumar to share his ideas on this wonderful drug. Over to Suresh Kumar.
Thank you, sir. Thank you so much. If I can allow to share my slides. First of all, I want to profusely thank Dr. CRS and Ramakrishnan for agreeing to chair this session. In fact, I agreed to Sun Pharma to talk on this mainly because of Dr. CRS' presence here. So because I'm tired of hearing my own voice very often these days. So I thought, for a change, I will stop talking. But I think when they told me that you're going to be the chair for the session, I readily agreed. There's a good opportunity to interact with you. Thank you very much for being the chair today. So today, I would give it an outline. First of all, I talk about anxiety disorders because I think it's very important for us to begin by understanding anxiety disorders. Then I'll talk a little bit about the benzodiazepines which already Dr. CRS has talked extensively. And I talk particularly about the GABA A receptor. And etifoxine is the topic of concern today. And I'll end by talking about some clinical studies and key highlights. So let me begin by talking about anxiety disorders. This is a quote from Robert Burton, the author of The Anatomy of Melancholy. Dr. Somasundaram always used to insist on us to read about The Anatomy of Melancholy. And if you read, Robert Burton quotes Hippocrates by saying that in Hippocrates' description, he actually describes social anxiety in those days by saying he dare not come into company for fear. He should be misused, disgraced, overshoot himself in gestures or speeches, or be sick. He thinks every man observes him. So this is a very classical description of what we today known as social anxiety. Hippocrates actually done that early on. If you look at the anxiety disorders, they are extremely prevalent across lifespan. Phobias begin very early in childhood. Thankfully, they begin to decline over a period of time. Worry is a common feature that occurs from childhood to adolescent to adulthood. But unfortunately, the worries increase again when persons become a little older. PTSD and panic are predominantly problems of adolescents and adults, whereas fear of falling is a very classical anxiety symptom that's prevalent only among older people. It's only older people who fear falling. Usually it doesn't happen with other people so much. So that's a kind of a presentation that happens over a period of time that we must be aware when we are dealing with populations. Many people believe that anxiety disorder, even though it's very extremely prevalent, think it is a common mental health problem. That really means that it is a mild mental disorder. There was a concept like that earlier on, but we do know anxiety disorders are disabling and chronic. If you look at the disability adjusted life years lost for mental disorders themselves contribute to 20% of all disability put together, in which anxiety only is second to unipolar depression. So anxiety disorders contribute about 4% of the total disease burden in the world. So that's a very disabling disorder. There are some common risk factors for anxiety disorders. Typically, is the family history of anxiety, and people who have a personal history of mood disorder have a comorbid anxiety disorder. It's very common in clinical practice to find both, unipolar depression as well as anxiety disorder. Childhood stressful events and trauma is an extremely important predisposing risk factor for anxiety disorders. Unfortunately, being a female is also a risk factor for anxiety. Both anxiety and depression are more prevalent among females than in males. And chronic medical illness is often associated with anxiety. That's why you see anxiety in medically ill population. So these are the common risk factors one would be thinking about. If you think about the pathophysiology of anxiety, you come up with the biopsychosocial model. In the biological factors, as I already said, the genetic factors are important. But today we do know the neural chemistry as well as the neural networks are important in contributing to biological factors. Some of the substances that people use, even including medicines, can contribute to anxiety. Sometimes the nutritional causes also contribute to anxiety. These are all the biological causes. But when it comes to psychological causes, I think the personality factors are important. Low self-esteem, cognitive dissonance, repeated negative emotions, inter and intrapersonal conflicts, that's very important, and developmental conflicts, how you perceive a situation, they all contribute to anxiety disorders. But not to miss the social factors, the contribution of social factors to anxiety is also very important. Adverse life experiences can impact and produce anxiety. We saw during COVID, the whole population, entire population in the world went through anxiety. That can be considered as a social adverse life event. And lack of social support, stress at work, lack of social skills, changing values in the society, conflict in the social norms, and natural calamities all can be called as social factors contributing significantly to anxiety disorder. So when we talk about anxiety disorder, we need to consider this biopsychosocial model, understanding it. What really we are interested in the past 20 years, we have come to understand there is also the brain behind the anxiety disorder. People have identified what they call as a fear network. The fear network indeed consists of some subcortical structures like amygdala, hippocampus, thalamus, the junction box, I would call it, the striatum, and then the sensory motor cortex, insula, very important organ involved in fear network, and anterior cingulate cortex. So the hyperactivation of the fear network, concurrently, there is a hypoactivation of the prefrontal cortex. That's what really happens in anxiety disorder. Whereas some of the subcortical structures are hyperactivated, predominantly from amygdala and hippocampus, there is an hypoactivation from the prefrontal cortex that actually contributes to the fear-based anxiety disorders. So that would be the easy way of understanding the brain behind fear-based anxiety disorders. But just this is a cartoon that will actually describe how the amygdala-driven fear and anxiety are actually regulated through bidirectional connections between ventromedial prefrontal cortex and the anterior cingulate cortex. And along with it, there is a crosstalk between these regions and the hippocampus. Just to illustrate that this cardiothalamic striatal circuits are predominantly important for the whole of psychiatry, including in anxiety disorders. Now, beyond the brain-centric anxiety disorder, I think the whole body is also involved in producing anxiety disorder. I think notable among them is a contribution of inflammation to anxiety disorder. I think inflammation is considered as a very important contributing factor to anxiety disorder. Traditionally, we have been told right from our DPM days, the hypothalamic pituitary axis plays a significant role, particularly in anxiety and depressive disorders. And immunological disorders, immunity is also very vital in contributing to anxiety disorders. And I think oxidative stress is also playing a significant role in many neuropsychiatric disorders, including anxiety disorders. Gut microbiota actually plays a significant role in anxiety disorder. We'll be hearing more and more about the relationship between gut and mental health in the coming years. So there is a somatic physiological processes that are also very relevant in anxiety. So today, the problem in psychiatry is we do not have biological markers for many psychiatric disorders. That's one of the reasons why we are being, ridiculed and then, not considered as a science by many people. But I think in future, we will be looking for biological markers in many neuropsychiatric disorders, more so in depressive disorders and anxiety disorders. If you look at anxiety disorders, already there are certain biological markers that have been identified that could be related to neurotransmitters, whether it's been serotonin, norepinephrine, GABA, or dopamine, or it could be related to neuropeptides such as cholecystokinin, neurokinins, and oxytocin. I think these are very important neuropeptides that also play a significant role as a biological marker. And I think the neurotropic factors like BDNF and NGF are also contributing a lot to many psychiatric disorders. And HbA axis markers are also relevant. This can be done today in any laboratory. And I think these are good biological markers for anxiety disorder to substantiate your diagnosis. And I think there are many immune markers that will go well with anxiety disorders and depressive disorder. Specifically speaking, carbon dioxide hypersensitivity closely associates itself with panic disorders. Again, neurophysiology. Today, all of us have gadgets in our hands. I think the smart watch, which Dr. Sridhar introduced to me a long time back, and I think this smart watch can be a good way to understand some of our features like heart rate variability. The heart rate variability could have a very significant relation to anxiety disorders. And I think neurophysiology marker can also include EEG. The EEG is a very specific biological marker in many neuropsychiatric disorders, including anxiety. So we also look at some biological markers for anxiety disorders in different places. You can look at the saliva. From the saliva, you can do the cortisol, lysozyme, alpha amylase. In the blood, you can look at serotonin, BDNF, cortisol, and microRNA. In the neuroimaging, you can look at actually the structural changes. Today, we have sophisticated MRI techniques, which will actually measure accurately the size of the amygdala and hippocampus and tell you the variations over a period of time. That kind of advanced technology is available in Chennai at this point in time. They can actually tell us and instruct us how this neuroimaging could be very useful in future. And again, CSF, though, is an invasive procedure. This can also be a biological markers like oxytocin and 5-HIAA could be also be detected from CSF, at least for research purposes. These are the various biological markers which are actually available for anxiety disorders. The question is, when we talk about anxiety disorders, under which there is a lot of disorders that are grouped together. At least there are 12 disorders that can be once upon a time considered as anxiety disorders. Thankfully, 2 of them, the trauma-related and stress-related disorders, and obsessive-compulsive and related disorders, have been separated by DSM-5. But a lot of people even question whether it is the separation is right or not, because the underlying pathophysiology seems to be anxiety. So in the anxiety, there are about 12 things that includes from the childhood onset separation anxiety disorder, selective mutism, to substance-induced disorders. Common among the one that we always see is the generalized anxiety disorder, panic, and agoraphobia. So when you see anxiety, there is a quick way of coming to understand what we are dealing with. If there is a history which clearly tells that it is very severely accompanied by depression, then you don't consider anxiety. Hierarchically speaking, depression comes first than anxiety. So if you see moderate or severe depression in this individual who's also presenting with anxiety, you start treating the person for depressive disorder. But when the person has a predominant symptom focus on trauma or flashbacks of memory coming back again and again to him, you probably rule out PTSD in this individual. If this person has obsessions and compulsions predominantly, you actually check for OCD disorders. But when a person has uncontrollable worry about several things, I think you need to look at generalized anxiety disorder. If it is an intermittent panic or anxiety attacks with avoidance, I think we should be looking at, if it is predominantly, if it is a social anxiety, you look at social phobia. If it is due to discrete objects, I think you look at simple phobia. And if it is intermittently occurring, and I think it's spontaneous and erupts suddenly and comes down, and I think then you check for panic disorder. That's a quick way of understanding how you can quickly come in a clinical setting to diagnose what you're dealing with. What are the important messages we need to give in populations? That's why we begin through SCARF, our work in school-based interventions. We strongly believe if you provide early targeted interventions at a formative time, particularly the middle age between 12 and 15, when the brain is developing faster. And I think in that stage, early targeted interventions, when the person has not developed symptoms of anxiety, it can actually reduce clinical anxiety disorders. We'll be looking at randomized clinical trial in schools, and then we'll be looking at and saying whether anxiety reduction occurs in children between the age of 12 and 15 when we are actually comprehensively providing targeted interventions, which we believe are going to be addressing not only well-being, but also reduction in clinical symptoms. So that kind of a thing is very important in a public health perspective. Secondly, even if somebody has developed anxiety symptoms, very early on, if you provide targeted therapeutic interventions, it's going to reduce the severity of anxiety symptoms and the complication of anxiety symptoms. So I think this is an important message I want to communicate here. It is not as though that as clinicians, our duty is to only provide treatment to severe anxiety disorders present in our clinics. I think we should shift our focus to communities, ecosystems of different kinds like schools and communities, where we can provide preventive interventions to prevent anxiety and to early interventions to make sure that the severity is reduced. So we are actually embarking on such kind of a journey from the Youth Mental Health Department of SCARF. So if you look at the clinical recommendations, what is provided for anxiety disorders, you will understand and will be surprised. The level A evidence is only for psychotherapy, particularly for CBT. But in a country like India, where trained clinical psychologists who are trained and well-versed in CBT is very few, this may not be applicable to vast majority of the population. Even with the level A evidence, this could be only delivered to a certain group of people. So I think that's a very challenging thing for us. The level B evidence is for physical activity. I think this is very important. I think Dr. Vijay Raghavan and their group in SCARF are actually embarking on a study of how important physical activity is to reduce mental health issues, including generalized anxiety disorder and panic disorder. I think physical activity is cost effective and it receives a grade of level B in as much as an SSRI will do the trick or a benzodiazepine combination will do the trick. So I think we have a good evidence for physical activity as a first-line treatment for anxiety disorders, at least for mild to moderate type. And lastly, I think the level C evidences are only for relapse as well as for whether we can tailor the infection, indicated treatment to certain specific individuals in a particular way. Tailoring the intervention is a very difficult one, and I think that will be a level C intervention. See, another way of approaching the treatment recommendation is if somebody is at risk for mild anxiety, you probably don't have to institute medication at all. Many people suffering from anxiety disorders don't require treatment. They require just a watchful waiting or sometimes provide, possible to provide the psychotherapeutic interventions like CBT. Moderate intervention, either it is CBT or pharmacotherapy or both. Only for severe and treatment-resistant anxiety, you need to combine pharmacotherapy with CBT. So that's the kind of advice we have at this point in time. I also want to point out here, in the past few years, there is so much of work that's being done in the world on anxiety than never before. And I think Wellcome Trust has put in quite a lot of funds to distill the active ingredients that are associated with anxiety disorder management. Even now, there are calls to researchers to identify and distill active ingredients for anxiety disorder management. I think to begin with, if you look at the brain and body functions, this is where most work has already been done. As medical professionals, we have contributed a lot. For example, correcting the circadian rhythm that could impact on the anxiety disorder. Gut microbiome will become a favorable target for treatment in future. Reduce levels of inflammation through anti-inflammatory agents that will again become the future. Currently, today, we have SSRIs that alter the anxiety disorder. These are active ingredients when it comes to biological interventions which act on the brain and body. But there are many more things that are also important. If you come to behavior and attitudes, we all know about it, intuitively know about it for long years. But actually, do we do it in clinical practice? Do we actually ask people to behaviorally activate themselves? Do we ask them to engage with arts? Do we actually allow people with fear to exposure and physical activity, problem solving, relaxation techniques, including yoga? All this could be part of the package for behaviors and attitudes. And when it comes to beliefs and knowledge, self-evaluation and sense of mattering is important. And I think that human connectedness, the social connectedness, the human connections are also very important in contributing to anxiety. If you reduce the loneliness, particularly among older people, if you increase the neighborhood cohesion for young people and adolescents, and if you improve the social relationship, if you improve even the digital quality social connection, at the moment there is a negative digital quality social connection occurring through many social media groups like Instagram. I think we need to change it to a positive quality social connection. All this could be active ingredients for anxiety disorder. And I think a lot of people involving in CBT and other psychotherapy focus on cognitive and attentional skills And I think affective awareness, decentering, emotional regulation, many of these things are being translated into an intervention and modular form, and we are running it. Not to forget the big factors like socioeconomic factors, just the cash transfers to people who are poor. And I think that's happened in Brazil, reduces the distress among population. These are population level active ingredients that could be important. Again, the importance of nature and the access to green spaces is now being talked about a lot when the climate change is being talked about in the world a lot. I think urban access to green spaces, the cities which have urban access to green spaces, people have less anxiety in those cities. See, these are some of the anxiety mitigating active ingredients that have been identified. I'm sure many more will come in the future, and they can be used as mechanisms for change when we provide treatment for anxiety disorders. So I'm going to be finishing with the section on anxiety disorders and move to benzodiazepines, which Dr. CRS classically described as a group of drugs that have been used for a long period of time. Ever since we know medicine, I think we have been using these medicines for a long period of time. We've been introduced to benzodiazepine right from our medical school days, and we continue to use it because of its popularity. So, as you all know, benzodiazepines are psychoactive drugs. One of the reasons they are scheduled drugs. One of the reasons I think in the years to come, you're going to get it difficult to prescribe benzodiazepines more and more to people because there is more and more rules and regulations in many parts of the world. Now it's also coming to India. It's not easy for people to obtain benzodiazepines like the way they used to obtain earlier on. And I think that's a very important point we need to remember. Benzodiazepines primarily work on the GABA-A receptor. And the GABA-A receptor is what I'm going to be talking a little bit about, because this is also the site in which, the new drug also is acting. GABA-A receptors are heteropentametric ligand-gated chloride channels. Basically, these receptors are ion channels. They are chloride ion channels. GABA can activate them, and it allows chloride to flow in. And when it happens, when the chloride ion flows in, it makes the cell to become hyperpolarized. And obviously, there is a less firing of the neurons, the inhibitory effect that takes place. So the chloride channel opening up is very important. And I think GABA-A receptors do that work. It's a ligand-gated chloride channel. So there are 3 types of GABA receptors, A, B, C. The focus here is on GABA-A. And if you look at the major isoform of GABA-A receptors, there are 5 units. That's why you see the pentametric ligand. So the 5 are 2 alphas, 2 beta 2s, and 1 theta 2. So they're all grouped under the central ion pore. That's exactly how this ligand-gated chloride channel looks like. You can see the cartoon and appreciate that. If you look at the binding sites of GABA, where the GABA, the neurotransmitter, binds itself, and it binds itself as the interface between alpha 1 and beta 2. Whereas benzodiazepines are binding at a different interface between alpha and theta. So the binding site of GABA is slightly different from the binding site of benzodiazepine. So benzodiazepine is going to be an allosteric modulation of the GABA. That's what it does. So if you look at benzodiazepines, I think I don't have to go over it. Every psychiatrist is familiar with that. There are some long-acting benzodiazepines. There are short-acting benzodiazepines. The difference we need to know, because I think short-acting benzodiazepines are the ones which cause a lot of dependence simply because of the fact that they have to medicate themselves many times. And please remember, benzodiazepines are not just anti-anxiety drugs. They can also be used as a hypnotic, which is what many people are using it for sleep disorder, rightfully or wrongly. And it's an anticonvulsant. Still, in status epilepticus, we still use diazepam as a key drug to control, status epilepticus. So I think there are many anticonvulsant properties of many of these anti-anxiety drugs. If you talk about benzodiazepines, the key thing to remember about benzodiazepine, they primarily work on the GABA-A receptor. As I said earlier, the binding site is slightly different from where GABA binds. It is on alpha and theta subunits. What they do, benzodiazepines induce a conformational change in the GABA-A receptor, which means once it makes a conformational change in the GABA-A receptor, it's going to allow GABA to bind to the GABA-A receptor. That's what it does. This alteration actually makes the calcium channel to open up, and it hyperpolarizes the cell. And this accounts for the inhibitory effect of benzodiazepines on the central nervous system through GABA. This is how benzodiazepines are working. And so if you look at the benzodiazepine mode of action, so as I said, as soon as the hyperpolarization occurs, there is less firing of neurons. The less firing of neurons occurs in almost all parts of the central nervous system. If it occurs in the spinal cord, that is why it leads to muscle relaxation. If it occurs in the amygdala-centered circuit, it reduces the fear, it reduces the panic, it reduces the phobia. If the firing of neurons is happening in the corticothalamic striatal circuits, then there is an anxiolysis that takes place, which is where it is useful in many anxiety disorders. If it is going to lessen the firing in the cerebral cortex, that's what it will lead to lessen the seizures and produce hypnosis and sleep. And the same mechanism of lessened firing is also responsible for its adverse effects, which are all worried. One of the adverse effects is the short-term memory defects, anterograde amnesia we see in individuals. People who take benzodiazepines sometimes appear very confused, particularly older people or people who take large doses. They can be ataxic, they can be slurring, they are very weak in the muscles. So these are some of the adverse effects you see. And in the long run, people also have dependence and tolerance due to benzodiazepines, which is the biggest worry. That's why in many, many countries in the world today, there is a restriction on the long-term use of benzodiazepines. They're strictly saying benzodiazepines cannot be prescribed for more than 4 weeks unless it's completely justified. But unfortunately, in this country, there are people who take benzodiazepine for years together. And I think overdose is one concern, but rarely, if it is taken alone, it is never lethal. It's a combination. It's a cocktails. It's always a problem. Cocktail with alcohol, cocktail with other, and cerebral depressants, which is a problem, which leads to respiratory depression. So I think we all know the reduction in the firing, the inhibitory effect, has both positive and negative impact on the central nervous system. So at the moment, why are we not happy with what we have? We have a number of medications that is available to us, but there is a huge unmet need. The unmet need is, what we are looking at is, we want medications which are better tolerated and more efficacious. We want to identify people who are not responding to conventional medications and provide treatment to them. We also need treatment for people who don't respond to treatment and refractory to treatment. We don't know whether treatments that are available today are actually preventing relapse, whether they are promoting resilience in individuals so much so they can be without anxiety in future, whether this effect of the medication that we give have a long-lasting response through neuroplasticity. That's also really not too sure about it. So this is so much of unmet need, and current medications have a limitation. For example, SSRIs. SSRIs are supposed to increase the suicidal ideation, at least in the first weeks that we provide to them. And SSRIs have significant upper gastrointestinal bleeding. That's why gastroenterologists don't like us when we give such large dose of SSRIs to people. And one of the concerns in the older age is even SSRIs can increase the risk of falls and osteoporotic fractures have occurred in people who have taken SSRIs. Tricyclic antidepressants, thankfully, many people are not prescribing, excepting people of my generation, because of its cardiac toxicity and fatality and the toxicity associated with that. I think new generation of psychiatrists are not at all using a tricyclic antidepressants. So, whereas when it comes to benzodiazepines, I don't have to repeat. The side effects of benzodiazepines are well established and known for everybody. Among the geriatric population, I think there's a huge risk of falls and fractures. If you have a human, elderly individual who's been prescribed clonazepam or alprazolam, invariably we need to advise about people's mobility because there's a high risk of falls and fractures in these individuals. I think benzodiazepines, as Dr. CRS was talking about, produce sedation, fatigue, ataxia, slurring, memory impairment, and weakness. So that leads to a lot of motor vehicle accidents. We don't know. We only look for alcohol in these individuals. We don't know whether people have been consuming benzodiazepines that has contributed to accidents in our country. So there is also additive effects of alcohol combined with benzodiazepines, which is a serious problem. And so careful monitoring and vigilance is required when people are put on benzodiazepines, which I'm afraid is not happening in this country at this point in time. So this is basically the fundamental way in which benzodiazepines are at this moment. So I finished with the sections on anxiety disorders, gave you some kind of overview about anxiety disorder and a bit of a thing about benzodiazepines. Now I move to the subject of etifoxine. Etifoxine has exactly like benzodiazepine, and I'm afraid to say this is not a new drug. This drug was approved in 1979 in France. 1979 in France, it has taken so many years for the drug to come into India. So it's not really a new drug. It's a old wine in a new bottle. Etifoxine is an anxiolytic, anticonvulsant drug, but it belongs to benzodiazepine family. So the anxiolytic-like properties of non-benzodiazepine compound have been documented very well in both human beings and animals. A lot of animal studies are there, human being studies are there. They clearly point out etifoxine has anxiolytic-like properties. It is approved in India in 2023 December, and in other countries, 53 countries, most of them are from South American countries, East European countries, and South Africa, Thailand, Ukraine. These are the countries in which the drug is approved and available. The original country in which it was approved was France. I think France is one of the countries which prescribes etifoxine a lot. It's been approved from 79. I think the drug has been in the market for over, 40 plus years in, France. So etifoxine, what is it indicated for? It is indicated for psychosomatic manifestations of anxiety. That's where its prescription is. That's where it's indicated for. I want to talk a little bit about the mechanism of action. We all know about the mechanism of action of GABA receptors. Benzodiazepines. Benzodiazepines act through GABA A receptors directly through a binding site between alpha and theta. Whereas etifoxine has a dual mode of action. One, it directly potentiates GABA A receptor. But the site is different from where benzodiazepine is working. The site is not the interface between alpha and theta. It's a site which is confined to beta unit, usually beta 2 and 3. So there is a direct potentiation of GABA A receptor activation through an allosteric modulation from a site that is different from benzodiazepine. It also modulates the GABA A receptors by stimulating the neurosteroid production. So it's fundamentally the mode of action is slightly different from benzodiazepines. That may be the reason why the side effects that we have in benzodiazepines are not here in this etifoxine. Let me first talk about the direct potentiation. Directly, what does it do? It actually binds to the site in the beta subunits. So what is most important for etifoxine action is the beta subunits, marked preference for B2 and B3, beta 2 and 3. And what it does is the allosteric modulation, exactly like the way benzodiazepine does a positive allosteric modulation. And it opens up the chloride currents, resulting in hyperpolarization and an inhibitory response in the central nervous system. That's how the direct potentiation occurs. But when it comes to another action, that's very important because etifoxine is not just binding to the GABA A receptor, but it is actually also binding to the mitochondrial translocator protein, which is usually known as TSPO. Many of you know binding of etifoxine to the translocator protein, it favors the entry of cholesterol into mitochondria. Cholesterol is very important and it enters into mitochondria. And there it gets converted by several enzymes to very potent endogenous anxiolytics. The most important among which is allopregnanolone. People may be very interested in knowing about allopregnanolone because it's got a very good anti-anxiety and antidepressant activity. To illustrate that, the synthetic preparation of allopregnanolone is going to be available, is already available in the US as brexanolone. Brexanolone is indicated for treatment of postpartum depression. And I'm sure in India, we will have brexanolone coming in the future. So allopregnanolone, it's a synthetic molecule, is the brexanolone, which is actually working in postpartum depression. So allopregnanolone is the endogenous anxiolytic. That's what happens when etifoxine is binding to the TSPO and the cholesterol gets converted through several enzymes into allopregnanolone. So this is a neurosteroid, and this neurosteroid is a very potent allosteric modulator of GABA receptor. So together with these two actions, the direct potentiation on the GABA receptor through beta subunits and by inducing the synthesis of allopregnanolone, which is an anxiolytic, endogenous anxiolytic agent, together it produces a very synergistic and long-lasting anxiolytic effect. So whatever I said is actually put in this cartoon. What are the important things that I wanted to point out is the unlike the benzodiazepines, etifoxine acts on the mitochondria through this translocator protein and produces neurosteroids. That's why it's vastly different from the benzodiazepine action. Also, the binding site from benzodiazepine is different. Let's talk something about the translocator protein. The translocator protein is actually the one which is usually used to be called as a peripheral benzodiazepine receptor, but now it's found in the outer mitochondrial membrane. It's going to be interacting with the mitochondrial permeability transition pore, which is located in the outer mitochondrial membrane, as well as the adenine nucleotide translocator, which is inside the inner mitochondrial membrane. This is exactly where translocator protein is, and this is the site to which etifoxine is binding. What is the translocator protein involved with? It is involved with the cholesterol metabolism in allowing cholesterol to enter the mitochondria. And so this is very important. The translocator protein is very important, and it plays a crucial role in neurogenesis, plays a role in inflammation, it plays a role in steroid genosis. So neurosteroids are produced through this. So one of the important neurosteroid that is produced is pregnenolone, which is actually again converted into progesterone and deoxycorticosterone and other testosterone metabolites, particularly allopregnanolone. Of interest to us is the allopregnanolone, which is the most potent positive allosteric modulation of a GABA A receptor. You all know that it's an anxiolytic, mood-altering property it has. So what they do, they actually, by being an allosteric GABA A receptor, they increase the opening bus duration of GABA A receptor channel and also increases the mean open time. So more chloride can flow in a given time into this GABA receptors. I mean, into the ion channels open up and chloride flows in, and the inhibitory response is little long lasting. To summarize, what is the difference between the conventional benzodiazepine and etifoxine? As we repeatedly talked, benzodiazepines bind in the GABA A receptor between alpha and theta subunits, whereas etifoxine binds directly to the beta units. Both act by opening up the chloride currents, resulting in inhibitory response within the central nervous system. So what is important is the alpha subunit to which benzodiazepine is binding. That is the one which is responsible for the adverse side effects Dr. CRS was talking about, whether it is sedation, whether it is a muscle relaxation, whether it is a memory disturbance. All of the adverse effects are the result of is binding to the alpha subunit. Whereas etifoxine is not, like binding itself to the alpha subunit. It confines itself only to the beta. So it's devoid of the side effects that are usually associated with benzodiazepines. So there is no sedation, there is no amnesia, there is no muscle relaxation, and there is no tolerance and dependence in the long run. The fundamental difference between these two things and the characteristics are because of the way in which they are binding to the various sites. Okay, this is again a cartoon that describes the difference between benzodiazepines and etifoxine. Can somebody, switch off some of the noise that is coming in the background? Thank you so much. So benzodiazepines, etifoxine differences. Subramani, can you do something about that? Thank you. So benzodiazepines, etifoxine differences are noted in this, cartoon. The fundamental difference is if somebody comes with a benzodiazepine overdose, you can give a flumazenil, and I think corrected. You can't do that for this particular drug because the way in which where flumazenil is working is different. The site is different from the binding site of etifoxine. And etifoxine, please remember, acts not just on the beta subunits, but also binds to the mitochondria and makes sure that the neurosteroid is produced, and that is responsible for its anxiolytic effect too. So that's how it's different. So I want to look at and say, what is the advantage of etifoxine over benzodiazepines? One of the most important things is the mechanism of action. There is a dual mechanism of action compared to benzodiazepine. So, as I said earlier, because it's not combining itself to alpha subunit, there are many side effects that are associated with benzodiazepines that does not occur. So that's a fundamental difference. Apart from the anti-anxiety effect of etifoxine, we need to understand etifoxine also has greater neuroprotective effects. This is what I want to talk a little bit about. Etifoxine has a protective effect in the animal models on the neuroinflammation, nociception, and neurodegeneration, which means this particular drug is not just going to be useful only for anxiety disorder. It's got a potential benefit for other neurological and psychiatric disorders. Remember, because of its binding capacity through translocator protein and then facilitating the entry of cholesterol and metabolizing it to very important metabolites, I think this drug is very important in neuroinflammation, nociception, and neurodegeneration. Etifoxine also has an anti-inflammatory property because it reduces the production of pro-inflammatory cytokines by microglia. We all know that the inflammatory hypothesis of depression and anxiety is becoming very prominent, at least for some subgroup of people with lived experience of depression and anxiety. It is true. So in future, we'll be looking at anti-inflammatory agents for treating them. And etifoxine is one of the drugs that can actually potentially reduce the pro-inflammatory cytokines, at least in the animal models, by the microglia. So already there are decreases in interleukin-1 beta, interleukin-6, tumor necrosis factor alpha, and inducible nitric oxide synthesis were all observed in etifoxine-treated animals. So these are the inflammatory markers we could be looking at. Those people with inflammatory markers may be responding to this particular medication better than other drugs. Again, this drug can also reduce neuropathic pain symptoms in animal models. So dose like 50 milligram per kilogram in animal models have reduced the neuropathic pain. So it alters the nociception. Allopregnanolone induced by etifoxine probably is responsible for the anti-hyperalgic effects that are seen. So if the pain reduction may be due to this allopregnanolone, it's not only having an anxiolytic property, antidepressant property, but also have a property to reduce pain in these individuals. So it's got a wider spectrum of action than we think at this point in time. Can we have a look at the pharmacokinetics? The pharmacokinetics is after oral administration, etifoxine is rapidly absorbed by the gastrointestinal tract. The time to reach the maximal concentration is only 2 to 3 hours. It's mostly metabolized in the liver. One of the important metabolite is diethyl etifoxine, which is a very active metabolite. Unfortunately, it crosses the placental barrier, so it can't be indicated in people who are pregnant. Half-life is 6 hours. The half-life of the active metabolite is actually 20 hours. Mainly excreted in urine as metabolites, also excreted in bile. Small amounts are excreted in unchanged form. Etifoxine is available as a 50 milligram capsule. It's usually we require 150 to 200 milligram given in 2 to 3 divided doses. The duration of treatment is only indicated up to a few weeks, not in the longer run. It's only indicated up to a few weeks. Like benzodiazepines, it's only indicated benzodiazepines only for 4 weeks. And I think it can slightly extend a little more, but usually it's given for a few days to a few weeks. Use in special populations, I think as we know that crosses the placental barrier, we just cannot use it in pregnancy. We don't have sufficient data on how does it impact on the fertility, that can be given to breastfed people. These are data is not available. Unfortunately, the pharmacovigilance data from France has not significantly collected these issues. Both in people with severe hepatic and renal impairment, this drug is contraindicated. So another contraindication for this drug is people can be hypersensitive to this medication. So those who are hypersensitive to any active ingredient, one of the excipients of this drug should be definitely not given this medication. People who are in states of shock, who have a compromised liver and renal function, who have myasthenia, and who have had severe case of hepatitis earlier on due to the previous exposure. Because I think cytolytic hepatitis is reported with etifoxine, even though the cases are rare, it's been reported. And I think we should be careful in giving people who have had an experience with this medication earlier, not to give this medication. Of course, like cutaneous disorders are also reported. I think the worst ones are the dermatological syndromes like DRUS, Steven-Johnson syndrome, exfoliative generalized dermatitis. All this, I think if somebody had that experience, I think you should avoid it. If there is an evidence for it, when you provide treatment, you should definitely avoid it. So this drug, even though it's considered as non-sedative, is recommended. That is not combined either with alcohol or with benzodiazepines. I think if you look at this, the combinations that are recommended not to be combined are very similar to benzodiazepine, simply because it's actually binding to the GABA receptors, even though many of the things that you see in benzodiazepines are not occurring. Still, in the real world, some people can complain about drowsiness. That's a real reason why these combinations should be avoided. There is also a study reported from 2015 by Cochin and his colleagues, and I think this is an important one. Even though the drug has been approved in 1979 and been in market for about 40 years in France, this is the only pharmacovigilance study done in 2000 to 2012. During this 12 years, they've studied and they've identified certain, like spontaneously reported adverse events and analyzed it. And then surprisingly, the number of adverse events have been reported that includes cutaneous disorders, and then I think hepatic things like cytolytic hepatitis and certain other gastrointestinal symptoms. But I think the incidence of these things, even though it's very intimidating, is very rare. That's a positive thing that we need to note. So let me look at and say, for what I'm saying, is there actually a clinical evidence? I look at only 6 studies very quickly, because I would like to take some time to walk through some of the questions that you have in your mind. I want to really look at the clinical studies and say, one of the important clinical studies, I think there are 6 studies I'll be talking about. Okay. Now, first of all, we need to understand how does etifoxine function in normal, healthy adults and older people. Because we want to know whether somebody who's healthy can actually take etifoxine, or older people can take etifoxine, what really happens to them, right? So the second thing is whether etifoxine has been given in people with anxiety disorder and compared with already existing benzodiazepines like alprazolam or clonazepam. There are 2 studies, one done in India, one outside. And then also the adjustment disorder with anxiety is one of the very common disorders for which short-term treatment with anti-anxiety medication is required. This is a classical condition. Adjustment disorder with predominant anxiety usually resolves within few days and weeks if we provide anti-anxiety drugs. At the moment, we prescribe benzodiazepines, and I think many people become dependent on it. So we are looking for an alternative. So whether etifoxine can be useful in adjustment disorder with anxiety compared to alprazolam and lorazepam. Those are the 6 studies we'll be making a brief mention about. The first one is on the healthy volunteers between 18 and 35. And I think these 18 and 35 volunteers have been given. This is a 4-arm study. One arm has received 50 milligram. The other arm have received 100 milligram of etifoxine. The third arm have received, the comparative arms have received 2 milligram lorazepam and 1 placebo. So these have been followed up for a period of time, and I think healthy volunteers were randomized, and then they were actually studied for the endpoint after given, right? The endpoints were studied. One of the important endpoints that were studied is what is the psychomotor performance when they take in the drug. If you look at subjects who have taken lorazepam, displayed significantly longer choice reaction times. So they are very slow to react to certain things. So the psychomotor performance is definitely more impaired in people on lorazepam than on people who are taken etifoxine. This is on healthy voluntary individuals. You take it and then you go through the test. The other test is whether etifoxine is impairing the performance in a barrage test. I think lorazepam significantly impaired performance in the barrage test, which is a test of vigilance. So people are less vigilant when they are on lorazepam compared to etifoxine. The third thing is about the memory. People who are taken 2 milligram have a significantly delayed, immediate and delayed recall than subjects, the 3 other groups. Whereas we didn't find any big difference in the digit span and reverse digit span, which always we do. And I think reverse digit span for attention, that is not impaired. What is really impaired is the immediate delayed recall. So compared to etifoxine, lorazepam seems to be affecting the psychomotor performance, vigilance, and memory. Similarly, compared to etifoxine, lorazepam, people on lorazepam felt very tired and woozy through the visual analog scale. And in terms of safety, we all know that through this study, etifoxine, 50 milligram and 100 milligram, do not produce the significant side effects that lorazepam people have gone through, including amnesia and sedation. So we can declare that this is safe if healthy individuals take the drug. The second one is what happens when people take etifoxine among older people. These are people between the age of 65 and 75. That was 18 and 35. This is 65 and 75. And people after taking this have been administered a neuropsychological test and CANTAB for actually assessing alertness and cognition. That's very important for older people. What happens to the alertness and cognition of the people when they are on this medication? Comparative dose is about 2 milligram lorazepam. And so compared to placebo, a single dose of 100 milligram had no deleterious effect on the alertness as evidenced by the CANTAB RTA test. So it's actually, it's like it does not alter the alertness. That's exactly what this, studies indicated. On the other hand, lorazepam actually increases the reaction time. So the alertness is delayed in these individuals. So 100 milligram etifoxine did not have any deleterious effect on the attention of the individual. In the Stroop test, as well in the CANTAB rapid visual information processing, comparative results were obtained between etifoxine and placebo, whereas it did not produce any memory disorder, with no visual problems or working memory disturbances. On the other hand, lorazepam impaired the alertness, impaired the attention, both working and verbal memories were disturbed. So that's something that happened with healthy volunteers, adults and older people. Safety, I think because the etifoxine did not produce any kind of a change in the alertness and did not impair the cognitive function, it was considered to be more safer compared to lorazepam. Okay. The third study is a study done in India, which is actually looking at etifoxine in comparison to alprazolam in generalized anxiety disorder with somatic symptoms. The population that they were treating is, the sample that they were treating is generalized anxiety disorder with somatic symptoms. They were actually testing the efficacy and safety of etifoxine in comparison with alprazolam. The dose of alprazolam was 1.5 milligram, which is 0.5 milligram in 3 divided doses. Etifoxine was given at the dose of 50 milligram in 3 divided doses. So people are followed up to 28 days. The Hamilton rating scale was a primary endpoint. Through the Hamilton rating scale for anxiety, there was a significant reduction compared to the comparator alprazolam, right? So the comparator drug, both is produced, and I think in visit 5, there was a significant reduction from baseline to 28 was comparable to comparator arm. From the change to baseline to Hamilton was also obtained in psychic subscore, somatic subscore, global impression severity scale, global impression improvement scale, and also there was no change that was seen in the cognitive assessment at day 18. Just to indicate, this drug is non-inferior to alprazolam in the sense that we were able to manage, anxiety with etifoxine as well as we did it with alprazolam, but with the caveat that it produced much lesser side effects compared to alprazolam. The fourth one is a study that compared 150 milligram etifoxine and clonazepam 1 milligram in people between the age of 18 and 60. And again, and I think the endpoints were more in favor of etifoxine, superior to clonazepam. And we can only conclude that we can't conclude. In fact, even though the points were in favor, but statistically significant. And so the clinical improvement, we can say that's non-inferior to clonazepam. So the non-inferiority of etifoxine compared with alprazolam and clonazepam is very well established in these 2 studies, one Indian, one outside of India. The last one and the last 2 are the ones that are used in the adjustment disorder with anxiety, one with alprazolam, another with clonazepam. The study design is pretty much the same. Etifoxine 150 milligram in comparison with 1.5 milligram alprazolam. I think you will see that this particular drug improved the anxiety symptoms on day 7 by say 70. When you discontinued the medication, this is the tricky point. When you discontinue benzodiazepines, people have rebound symptoms coming in. When you discontinue medication from etifoxine, I think people are not complaining of any relapse of symptoms or recurrence of symptoms. That's one thing that you would see. Similarly, with clonazepam, with the dose of lorazepam, with the dose of 2 milligram, people also did not see when they were withdrawing the medication, they didn't see any withdrawal side effects. And I think there was a improvement seen both in the Hamilton score as well as the clinical global impression. Just this study I went through very, very quickly because they're not very rigorous studies. They're not RCTs and, simple study designs. I think we can just say that this drug is safer in adults who are healthy, and this drug is non-inferior to the existing benzodiazepine. And I think where it should be most useful is in people with adjustment disorder, with anxiety, because we can withdraw the medications quite successfully after a period of time. So I'm going to summarize my long talk by very few points to carry home. At the moment, anxiety disorders, even though prevalent, is a very disabling condition. To me, I feel preventing anxiety disorders through targeted interventions starting very early on is very important. Providing early targeted interventions will reduce the severity. We have a number of pharmacological options other than the number of variety of psychological and behavioral interventions as active ingredients I talked about. As medical professionals, we have pharmacological interventions, wide range of medications, anti-anxiety medications available, including benzodiazepines. The problem with benzodiazepine, even though it's commonly prescribed, widely prescribed across board by everybody, including physicians and psychiatrists and neurologists and everybody, they are associated with unwanted adverse side effects. And I think geriatric patients are more vulnerable because of the fall and fracture. On the contrary, etifoxine, because of its inherent dual action, actually is not only efficacious drug as an anti-anxiety drug, because of its non-binding to alpha subunit, it can be devoid of some of the benzodiazepine-related side effects. So the potentiation of the anxiety alleviating effect comes from the neurosteroid allopregnanolone production. So the studies have also clearly indicated healthy subjects can tolerate this medication without being interfered with the attention and alertness compared to lorazepam. Or the phase 3 study of the Indian population on etifoxine and alprazolam also proved that people with generalized anxiety disorder with somatic symptoms, this is not inferior. And in people with adjustment disorder with anxiety, this could be a welcome drug. So I'm going to stop here. And I know I've taken a little more than what I wanted to take. Subramanian said stop at 9 o'clock. I said I'm stopping at 9 o'clock. Thank you. So over to Dr. CRS. I'm happy to take any questions.
Thank you, Suresh sir, for your excellent presentation. As usual, you simplified everything and you beautifully presented. And especially you presented the present status of anxiety, the present status of benzodiazepine, and also the present status of treatment for anxiety disorders, and also the present situation about the non-pharmacological treatment of anxiety disorders. Then you highlighted what are the disadvantages, especially long-term complications of benzodiazepine, and in what way the newer drug, the etifoxine, is superior to the benzodiazepine, and prove that you have highlighted certain clinical studies. It's really a fantastic the presentation, and also it gives a good insight about the whole thing. And I'm extremely happy to tell you that today, foregoing the goat experience, foregoing the Vale experience, and 143 Sunday outing, 143 people they have participated in this seminar mean the whole credit goes to Suresh Kumar. Hats off to Suresh Kumar sir. Now I request Ramakrishnan to share his views.
Thank you, sir, for giving this opportunity. As usual, when Dr. Suresh Kumar talks, it is like a fountain or a waterfall. So it cannot be stopped. With great difficulty, he has stopped his lecture. And as Dr. CRS told, it is he has given the whole scenario about anxiety. But all said and done, still the exact biology mechanism of anxiety is still in a mystery stage only, and we are like 5 blind people touching an elephant only. So ideal drug, so far we have been trying, but so far we have not got any ideal drug. Maybe this may have an advantage over the previously existing drugs, especially in the sedation point. That's one thing. And another point that they may be having cutting edge is about the neuropathic pain, the effect on neuropathic pain, as well as it has got some neuroprotective factor. It is reducing the neuroinflammatory pathways. maybe these are the cutting edges that may overtake from benzodiazepine drugs. But we have to wait and see because it is a novel nascent state. Only Indian studies has to tell it because pharmacogenetics is different. What works in France may not work in India. So that's how many molecules have gone away from India. It came with a big bang and went like this thing. So we have to wait and see. And to my little experience, still people find drowsiness as one of the side effects with my limited experience. So I think it is open for questions. I think how many questions, Mr. Subramaniam, people can ask? And there is some important questions I have seen over this thing. The primary treatment of anxiety disorder in SSRI, we give benzodiazepine to cover the late onset of action. So etifoxine may be used for that. Where do you place it? That is one question that has come. And another important thing what I have found out in the question. Well, Dr. Karthikeyan asked, will anxiety will be the game changer in psychopharmacological management? And another question that has come up is, how is it different from buspirone? Because it was a popular brand, a popular molecule in 90s and early 2000, buspirone. How is it different from buspirone? These are the three important questions that I thought has come up in the chat box.
Suresh sir,
Yeah.
Suresh sir, one more question. For example, the patients who are on benzodiazepines for quite long and not partially responding, I want to start with the trans anxiety, this drug. How to withdraw the old benzodiazepine and how to restart that, one. And second, you have told that the duration, you can give the drugs for 3 weeks or 4 weeks. Then after that, how to discontinue this particular drug?
Okay, let me summarize all those questions and try and answer as much as I can. Take the easier one. How is it different from buspirone? Remember, etifoxine is primarily a drug that has a dual mode of action, either a direct potentiation at the GABA receptor level, like benzodiazepine, excepting that it works at the different subunit, the beta subunit rather than the alpha theta interface. That's a important one. If the etifoxine, also by the neurosteroid production, it produces the anxiolytic effect. But the buspirone is a drug that is actually affecting the serotonin receptors, particularly as a 5-HT1A partial agonist. You all know that it is a 5-HT1A partial agonist. So any serotonergic activity of etifoxine is indirect. It has got no direct action on the serotonergic system, but all these systems are interlinked in one way or other. So working on the GABAergic system, it could have a secondary impact on the serotonergic system, whereas buspirone is directly working on the serotonin 5-HT1A receptor. And also, it could have some action on the dopamine receptor, but I think it's really not the one reasonable for its anti-anxiety property. So it is different from buspirone. That's a fundamentally easier question to answer. The second one, let's come to the difficult ones. So I am not too sure whether anxiety will be a game changer in the psychopharmacological management. It'll be actually helpful in many ways. The reason why it'll be helpful is currently we are going to be limited by generous use of benzodiazepines. Benzodiazepines, like in the West, is receiving a very bad press in India. Sometime back, benzodiazepines were glorified, like the way it was glorified in the 60s and 70s in the US. Now, many countries, many Western countries are becoming very tough with benzodiazepine prescriptions. So they're limiting the prescription. if the same is going to come to India, I think new onset anxiety disorder, even when you want to produce rapid reduction in anxiety, this is where benzodiazepines have been useful. They are never useful in the long-term treatment of anxiety disorder. It's only for the short-term treatment of anxiety disorder. That's why textbooks all described it. So you can probably replace benzodiazepine with etifoxine in the short-term treatment of anxiety disorder. You get it? You're not going to use etifoxine again in the long-term management, like the way you use SSRIs, for example. SSRIs can be used as an anti-anxiety drug for a long period of time, along with psychological measures like CBT. So etifoxine is not going to be indicated in the long run. It's going to be used like benzodiazepines for a short period of time. That is why I'm insisting people like adjustment disorder with anxiety symptom predominant. They are the ones who will be most likely to benefit with this medication. Or you want to treat anxiety very quickly, and I think you can reduce the anxiety instead of benzodiazepines, particularly when you want to deal with the older individual and a person who has already exhibited previous history of dependence and tolerance to benzodiazepines. These are the people who can be easily put on, like this non-benzodiazepine drug, and will be safe among them. You'll be having less adverse effects, yet will be achieving the anxiolytic effect in about 4 to 6 weeks' time. And you can probably start on SSRIs for them or concurrently start with them. That's how you'll manage anxiety disorder. But if somebody is already established on benzodiazepine, and I think I will probably hand over this case to my friends like Dr. CRS and Ram Subramaniam, because it's coming off benzodiazepine is a very big challenge. Coming off this GABAergic drugs like benzodiazepines is very difficult. We know that, people cannot even stop that 0.25 milligram alprazolam they've been taking for a few years. Try and stop that, and then you become an enemy for them straight away. So I think it's an adventurous journey we'll have to carry with them. Lot of work is required. They stop only when the medication is completely not available. They suffer for a few days and then they come off it. It is only those people who are on large doses of benzodiazepine, which are not the treatment-seeking people. These are abusing people. They are the ones who are going through seizures and other things. The treatment-seeking population will be very difficult for a psychiatrist to withdraw benzodiazepines. But actually, when the drug is not available, suddenly they go somewhere and suddenly realize that they are not able to procure clonazepam at all from the market because they don't have a current prescription. They have to stop it, and they suffer for a few days and stop it. And then when they come back, don't restart them on benzodiazepine. You can consider this medication. This is where it will be useful. And I think there's another question on, how do you manage the overdose? Yes, it's a very important question, because I think benzodiazepine overdose is easy to manage because, both are GABAergic drugs. Both are going to produce toxicity by over excessive GABA activity, which means the symptoms will be similar. CNS depression, respiratory depression, ataxia, and seizures paradoxically sometimes. It's a paradoxical. Actually, it's an anti-seizure drug. Some people can have a paradoxical effect like this. So typically what happens is the CNS depression, respiratory infection, and hypotension. These are in benzodiazepines. You'll manage with flumazenil. I think it reverses it because the action is flumazenil is acting on the same place where benzodiazepines are acting. Whereas this drug acting in the beta unit probably is not going to be helped by flumazenil. Actually, it can increase the seizure episode in this, seizure potential in this individual. So you need to provide only supportive care to them. Hospitalize them, provide supportive care, take care of the, whatever. If somebody has come very early, immediately, perhaps there I think activated charcoal may be important. But many times people land up very late, very, very late. And I think activated charcoal becomes a cumbersome procedure, doesn't really act. So we need to hospitalize and manage them. So benzodiazepine antagonists like flumazenil may not be a big place in this particular one. Is there any other question that I missed?
Hello.
Yes.
Sir, my question is, you told about this releases nitric oxide, sir. It means it improves the memory power, sir?
No. No, there's a difference between improving and not impairing.
This molecule release, sir, this molecule releases nitric oxide, you told. That means it's improve the memory power. Number one.
We do not have a clinical correlation to that particular biological factor that we have been observed. Nitric acid synthesis has been enhanced, but I think that can be considered mostly for its anxiolytic, anti-mood altering property, not necessarily for a cognitive. It preserves a cognition.
Okay, I understand.
Yeah, it preserves the cognition.
Yes,
I don't think we can at the moment promote it as a pro-cognitive drug. We need to have more clinical evidence for that. Thank you for asking this. It's a vital question.
Okay. Now, second is, it acts through the lichen channel, sir. Lichen gland means it acts any effect on the 5H3, sir?
Which one?
Because this molecule is acting through the lichen channel.
Yes.
That means it is any effect on 5H3, this particular molecule?
You know, direct serotonergic action is not there for this drug. It's primarily through GABAergic system. I think indirectly it might, work on the serotonergic enhancement. The action is not direct.
Okay, sir. One more thing, it acts on the beta receptor, you told, beta receptors. That means it may affect any cardiac involvement?
No, I didn't say beta receptor. GABA receptor has 5 subunits.
Oh,
5
GABA,
subunits.
okay.
2 alpha, 2 betas, and 1 theta.
Okay, thank you very
That's a unit under the isoform platform of GABA receptor.
Okay then. Thank you, sir. Thank you.
Thank you.
We can wind up this session and I hand over this to Professor CRS.
Subramaniam, can you propose the vote of thanks? Subramaniam?
I take this opportunity to thank one and all for sparing your valuable time on a Sunday evening. And as Prabhu told by you, sir, 142 people on a Sunday evening. It's a great gesture from all of us, sir. Thank you very much. And studies are all Indian studies only. We have done studies are all Indian studies. And studies are double dummy study also. So one of the double dummy studies. Thank you very much, sir. Thank you so much, Dr. Suresh.
Subramaniam, I want to make an important announcement.
Yes, sir.
Can I make an announcement?
Yes, sir. Please, sir.
From the organized point of view, we have arranged a dinner for all the participants in their house. Don't go. Your wife and husband, they are all waiting.
Yes, sir.
Don't waste
Thank
the
you,
food.
sir. Thank you very much, sir.
It is our humble request.
Thank you.
Yes,
Sir.
sir. Yes, sir.
Suresh, sir. Thank you, sir. Suresh,
Thank
sir.
you. Yes.
Thank you.
Sir.
Thank you, Suresh sir, for your
Thank you,
excellent
sir. Thank you so much, Dr. CRS and Dr. Ramakrishnan. Thank you
Thank
so
you,
much.
sir. Thank you, sir.
Sir, Suresh,
Thank you, sir.
Great doubt, sir. Sir, Suresh, sir. Sir, Suresh, sir.
Yes.
ஒரு டவுட் சார், ஒரே ஒரு டவுட் சார்.
சொல்லுங்க.
உங்களுக்கு ஒரு வாட்ஸ்அப்ல உங்களுக்கு ஒரு சாட்ல ஒரு டவுட் அனுப்பியிருக்கேன் சார். ஒரு டாக்டர் இப்ப கேட்டிருக்காரு.
என்ன?
உங்களுக்கு தெரிஞ்சவர் தான் சார், உங்களோட ஃப்ரெண்டு தான்.
The duration of treatment with etifoxine is only for 12 weeks. So it's only in weeks, 12 weeks. It should be combined with appropriate psychotherapeutic interventions. And it's actually very useful in disorders associated with stress, which is what I think we stress it on people with lived experience of adjustment disorders, where the predominant manifestation is anxiety. Thank you. Thank you so much for saying that.
Thank you, Subramaniam. Thank you.
Thank you.
Thank you, Suresh sir.
Thank you, sir.
Thank you, sir.